guess the best way to get this started is to just start talking. Maybe our proctors out there can let people know we're starting. We're going to change the order around a little bit. Stephanie has to get back to Philadelphia so that Dr. Spray can come in. They're tag teaming, as many congenital heart surgery programs do. So Stephanie's going to go first, and then Dr. Costello will be next. I asked Stephanie to talk to us about a very important topic, and that is the pulmonary valve replacement. I think more and more we're seeing patients referred who've had tetralogy repair, have pulmonary insufficiency, and now with the MRI imaging, we seem to have standardized the way we take care of these patients, but there seems to be more and more of them. Also, the introduction of the Melody valve has changed a lot of the protocols, at least in the minds of the cardiologists. So I asked Stephanie to address all of those different issues. So Stephanie, why don't you go ahead, and then we'll do the interesting question and answer session, I'm sure. Stephanie.
Thank you, Carl. I have no disclosures. If you look at the 2011 STS database for the adult database, basically of the 30,000 total valve replacements done in 2011, only 1% of those were pulmonary valve replacements. However, if you look at the congenital database and select out those adult patients, you can see that overwhelmingly half of the valve replacements, in fact, were pulmonic valve replacements, 56.6%. This still means when you put the two databases together that we are actually doing less than 1,000 pulmonary valve replacements annually. If you look at the congenital database, once again, these are the cases that we're doing. 965 total valve replacements done. That's more than half of the valves are pulmonic. Yet when you look at what other valve procedures are done on the pulmonary valve, overwhelmingly it is replacement. If you look at the age of our patients and who actually is surviving with complex congenital heart disease compared to the 1960s, where approximately 1% of the patients with DTGA and 10% of those with tetralogy of Fallot survived to adulthood, by 1980, overwhelmingly, 80% of these patients were surviving, and now those numbers approach 95%. As a result, we've seen a significant increase in the number of adults living with congenital heart disease, and we see approximately an increase of 20,000 patients, or a 5% increase per year. So residual pulmonary regurgitation is an important determinant of outcome in patients with tetralogy of Fallot, and what we see afterwards is an increase in right ventricular size, a decrease in right ventricular function, an increase in exercise intolerance, an increase in the propensity for arrhythmias, and an increased risk for sudden cardiac death. In fact, Gatsoulis looked at this several years ago. This was published in Lancet in 2000, looking at the causes of death in survivors of tetralogy of Fallot. 75% of these were cardiac, and sudden cardiac death actually accounted for approximately 40% of those. If you look more specifically at the predictors of sudden cardiac death, well, we can gain some of the predictors basically from a patient's history. Are they syncopal? Have they had a repair at a later age? Electrophysiologic data, patients who have an increased QRS duration, an incidence of SVT or sustained SVT. And lastly, hemodynamic information, basically enlargement of the right ventricle, the severity of PR, the severity of tricuspid regurgitation, and a decrease in ventricular function. I like to think of these patients basically in three categories. The first of those is those patients with symptoms, typically of exercise intolerance. And we kind of tend to group patients who have an anticipation of symptoms in that same group. For example, patients for whom, women in whom pregnancy is planned when they have twice the circulating blood volume. The other category that I tend not to think about so much in terms of the indication for pulmonary valve replacement are those patients who typically have an incidental pulmonary valve replacement. So these patients are coming in with residual from their first surgery, so either pulmonary stenosis, a residual VSD with significant shunting with a QPQS of greater than 1.5 to 1, patients who have severe PA enlargement, and some who have severely aneurysmal PAs up to 6 to 7 centimeters. And lastly, those patients with increasing tricuspid valve regurgitation. So it's really this group in the middle that's the asymptomatic patient on whom we have plenty of data, but we haven't really established a consensus about what to do with the data on those patients. Currently, I think the gold standard for looking at these patients certainly has become MRI. Our CMR protocol is what we use for patients with tetralogy of flow, and just to walk through briefly, basically what that includes is first we do static images. These are axial images. We basically look at the cardiovascular anatomy in these images. We take those images and then basically reformat them to come up with 4-chamber and short axis views that allows us to do the cine imaging. And then afterwards we can do phase-encoded velocity mapping on these patients. And this is really where we get the bulk of our hemodynamic data in terms of stroke volume, ejection fraction, cardiac output, and importantly, the regurgitant fraction. We can also calculate collateral burdens in many of our patients from that data. All of these MRIs are EKG gated. The indications, are they the same for all patients? So I didn't go through and pick a specific case. Instead, I gave you an example of some data. Patients with severe pulmonary regurgitation, those with mild to moderate tricuspid regurgitation, it's never just mild. Patients who have, let's say, an RV-EF, which is clearly depressed at about 40%, a normally preserved left ventricular ejection fraction, and patients who tend to have a large, but certainly not exorbitant, right ventricular end diastolic volume. And I challenge you to think about these patients differently because unfortunately we don't see this data blinded and we are biased towards our approach to patients. For example, if this was a 19-year-old sedentary male who basically attends college and waits tables 2 nights a week, would we necessarily do a pulmonary valve replacement on that patient compared to a 27-year-old female who is planning pregnancy? Or how about a 43-year-old single mother of 2, a 52-year-old attorney versus a 17-year-old NCAA athlete versus a 15-year-old high school athlete? And these are all patients in whom I've operated on for pulmonary valve replacement. If you look at the surgery itself, the risk of pulmonary valve replacement is actually relatively low. And if you look at this table comparing institutional results for pulmonary valve replacement, really the total for our mortality is actually approximately 1%. The indications for surgery in most studies suggest that restoration of pulmonary valve competency will help to decrease RV volume and size, to improve exercise tolerance and capacity, to decrease the propensity for arrhythmias, and to decrease the risk for sudden cardiac death, which is why ultimately we do this operation. It's questionable whether or not we see a decrease in QRS duration and whether we see a possible improvement in RV function. And I'm going to go through some of that data. I think just as guilty as we are of taking the data and applying it differently towards each unique individual, we're also guilty of basically treating the parameters that we use, most of these acquired on MRI, and instead treating them like an a la carte menu. We might choose, for example, that a patient who has a normal QRS duration, they have a moderate degree of tricuspid valve regurgitation or pulmonary valve regurgitation, yet they have an elevated RV end diastolic volume and a slightly depressed RV-EF, that's a patient we might operate on. Otherwise, we might choose that the patient we operate on is somebody who has moderate to severe tricuspid regurgitation, severe pulmonary valve regurgitation, and a depressed EF. And we kind of approach each patient by choosing from these various options of data, but without any clear consensus about what exactly one or more of these parameters we should be operating on for. If you look at the study published by Brian Cogan in 2009, the indications for pulmonary valve replacement by far and away at Emory were symptoms of the patients, but then otherwise we use parameters such as RV to LV ratio, RV dysfunction, and QRS duration. We have several suggestions for indications for pulmonary valve replacement, and Giva's report that was published in 2009 really is a very elegant paper that he published looking at not only what the indications are, but also what the progression is in terms of the effects of pulmonary regurgitation in these patients. And realistically, I tend to go with an RV and diastolic volume of greater than 160 cc's per meter squared, but I am as guilty as the rest of us in terms of not applying this towards all of my patients and being very selective with the data. If we look at thresholds for pulmonary valve replacement, Barbara Mulder and her group looked at basically hemodynamic changes after surgery and were able to conclude that really there was a significant improvement in RV end diastolic volume after surgery, RV end systolic volume. The RV ejection fraction improved in most patients. LV ejection fraction improved in most patients, and obviously the regurgitant fraction improved significantly. Yet they were unable to determine a specific threshold for any one of these certain parameters that dictates that now is the time to intervene. Does it improve right ventricular size? Well, Adamson did a nice literature review and looked at many of the studies that were published, and by far and away, each of these studies listed below, you can see that there is a significant improvement in most of these studies in terms of RV end diastolic volume after pulmonary valve replacement. If you look at those patients with symptoms, once again, a lot of this literature is overwhelming that patients with symptoms tend to get a symptomatic improvement from pulmonary valve replacement. And this is from 2001. Once again, this is looking at a study from 2007, a European study, looking at the improvement in NYHA classification for patients who underwent pulmonary valve replacement. Also, Graham in 2008 looked at 93 adult patients. He had a decrease in RV size by approximately 83% by echo, increase in systolic function, and the patient's both ability index and NYHA classification improved post-surgical. The study, however, did conclude that there was no improvement in arrhythmias afterwards. So in terms of our surgical options, moving on to technically what we're going to do for this operation, there are several examples in the literature of repair versus replacement for this. And for repair, most of these involve RVOT revisions and what's known as bicuspidization of the valve or the RV outflow tract. This very nice example that was published in 1986 looks at opening up the anterior pulmonary artery and basically invaginating that anterior pulmonary artery to create a flap as a neo valve, and then afterwards closing the RV outflow tract with an autologous patch of either pericardium or a patch of Gore-Tex. If we look at some of the techniques for repairing the incompetent pulmonary valves, overwhelmingly in the literature, most of the techniques involve lengthening of the leaflets. There's very little additional work that's been published on repair of incompetent pulmonary valve leaflets. But we can also reconstruct neopulmonary valves as done here using glutaraldehyde fixed pericardium. Looking at some of the techniques for valve repair, this bicuspidization strategy, which has been published many times, is actually a nice technique to use if you have viable leaflets that can be used. So typically, if you have a transannular patch in which the anterior leaflet has been divided, but the other two leaflets are still present and are actually in good shape, you can actually do a reduction pulmonary arterioplasty and in the process bring those two leaflets together in order to form a competent valve. The caution here is in creating either pulmonic stenosis or pulmonary incompetence, obviously, if those leaflets aren't suitable. If you look at the hemodynamics for this in 5 patients that were done, you can see that there was an excellent result with improvement in all these patients to either no or trace pulmonary regurgitation in 4 of 5 patients studied. 2 of the patients that they had in that series actually had to go to pulmonary valve replacement secondary to pulmonary stenosis afterwards. Another example here, published in 2012, of recycling the pulmonary valve is once again a similar procedure in which the transannular patch is excised and then the valve leaflets are brought together here as well. Looking at preoperative anatomy for valve replacement, we have a number of choices in terms of how we proceed with valve replacement. If I can, I typically favor doing an anterior horizontal pulmonary arterioplasty, very similar to a native aortic valve replacement. This allows for nice exposure to the valve. However, if you want to approach this by resecting the previous transannular patch, obviously a vertical incision across the annulus is a safe operation in patients who have had a previous transannular patch. And lastly, the modification of that is extending it onto the LPA more so than the RPA in case you need to perform a pulmonary arterioplasty for patients who have stenosis of the branch pulmonary arteries. In terms of considerations for valve replacement, I typically try to put the struts at 6, 10, and 2 o'clock. That tends to keep them off any of the coronary arteries and keep them from compressing any of the surrounding structures. The valve orientation, and Brian Cogan also in his nice review demonstrated actually the tilting mechanism of the valve, and I have an image of that to show you. We need to consider whether or not these patients need a pulmonary arterioplasty and possible RV remodeling, either by resecting a transannular patch or enlarging the RVOT. And then whenever I do these operations, I really try to be very generous and think about the future options for these patients. I'd like to save the patients from having a reduced sternotomy and preferably be able to really remodel the RV outflow tract so it's an ideal outflow tract for placing a Melody valve. If you look at valve replacement, obviously some of these strategies involve removing an old transannular patch. In some cases that will need to be replaced. In some cases not the entire patch needs to be replaced, but parts of the patch if we're able to actually bring enough of a redundant pulmonary artery anteriorly down to form the outflow tract that's actually distal to the new valve. Several of these examples are in the literature for replacing that patch, and I typically tend to do it as Brian illustrated here by affixing the new patch superiorly and then actually using it to reconstruct the annulus for the new pulmonary valve. This is also one of the most useful slides, I think, that Brian actually came up with, which was addressing the tilt of the pulmonic valve, and particularly in patients who might have a tendency to develop an RV outflow tract aneurysm or aneurysmal pulmonary arteries. I think it's very important that you maintain the normal geometry of the pulmonary valve, which actually points downwards and posterior towards the pulmonary artery as opposed to up towards the outflow tract. If you look at bioprosthesis durability, and there's several studies that have looked at this, there's actually only one randomized trial which compared bioprostheses to each other, in which the bovine pericardial valve was superior, but really time after pulmonary valve replacement tends to be quite good for the bovine prosthesis. The homograph obviously had had less of a durability, and we know most of that is usually due to development of stenosis as opposed to regurgitation. Also looking at prosthetic valve failure, and this was a study published in 2011, the freedom from prosthetic valve failure is actually pretty good. However, in this study looking at time after replacement, by 10 years, contradictory information here that actually the homograph tended to do better in terms of long-term as opposed to the heterograph. And most importantly, if you look at these patients in terms of age, we know that patients who have pulmonary valves or tissue valves implanted earlier, less than 5 years of age, tend to have a significantly impaired durability of that valve compared to their older colleagues. Part of this is probably due to the metabolism of the valve tissue itself, and part of the other reasons obviously has to do with the patient's resting heart rate and the opening and closing, hopefully, of this valve, which increases the wear and tear on the leaflets themselves, much like a door hinge. If you look at risk factors for prosthesis failure, this is published in 2012. Younger age and valve oversizing, interestingly, were both risk factors for prosthesis failure in this study by Chen et al. In terms of mechanical pulmonary valve replacement, this is becoming increasingly common, and from the literature I've picked two studies, one which looked at patients on an average of 11 years postoperatively with mechanical valves, and 3/4 of these patients were actually compliant with their Coumadin. That's probably a representation of what my population would be. And on follow-up echocardiogram, these patients were noted to have markedly improved RV function after replacement of their pulmonary valve. Not surprising, they had mild dilatation of their RVs, but they had mild residual pulmonary gradients as well. The RV hypertrophy was stable, and all these patients had 23 millimeter valves placed. If you look at the patients in another study, Walter Bach's study, looking at 27 mechanical PVRs, he had one early and one late mortality. These were basically due to complications of Coumadin, and one valve that failed due to pannus overgrowth. The mean follow-up here being 5.5 years. I know several other studies, including Durrani's study, looking at approximately 40 patients, looking at several patients over a 40-year time period, also shows very favorable results, but particularly for patients who already have a mechanical prosthesis in place. Looking at the percutaneous pulmonary valves, we use the Melody here at CHOP. Hopefully we will be using the Sapien at some point, but both of these are bovine jugular versus bovine pericardial tissue, which has been mounted in a stainless steel stent. For the Sapien, this comes in sizes up to 29 millimeters, whereas the Melody we're using up to a maximum of 25, and that's why my valve of choice that I put in patients is actually a 25 millimeter pericardial tissue valve, which provides a nice, actually, landing zone for the 25 Melody to be put in. Matt Gillespie loaned me these images, which show clearly in an AP and lateral views of a dysfunctional RV to PA conduit. We are only using these for RV to PA conduits at CHOP. We have not been using them in the RV outflow tract, despite having a transannular patch. And this shows both the relief of the conduit stenosis as well as the insufficiency. And in that figure 2B, you can see that there's really no regurgitation coming from that Melody valve. We used to do these strictly with angiogram. Now we reverted to doing them in XMR, which is an X-ray image. The patient goes to MR first. They have actually their MRI images imposed on the fluoroscopy as they're in the cath lab, which gives us a nice kind of three-dimensional sense of exactly what's going on inside the chest as that balloon is being dilated and as the Melody stent is being placed in these patients. So given that this is so much fun for a cardiologist to do, and they have all these nice, beautiful images, it really makes me question, what are we going to do once there's 2, 3, 4, 5, 6 Melody valves in the same place? And is that going to be a reoperation for us in terms of taking out these conduits once they have really a full metal jacket with significant stenosis there? If you look at the results of Melody valve implantation, early versus late functional outcome, the outcomes are quite good with the Melody valve. For patients who had these put in for pulmonary regurgitation, there was an improvement in RV systolic pressure, a significant decrease in the RVOT gradient, and also a nice improvement in the RV to systemic pressure ratio. However, there didn't seem to be much of an improvement in terms of function for these patients. Patients with pulmonary insufficiency tended to have no significant improvement of function. In conclusion, a lot of the longitudinal assessment of pulmonary insufficiency and RV function is very critical in the care of these patients. We're going to see more and more of these patients coming in with pulmonic valve interventions, and the optimal timing of pulmonary valve replacement, as I said, is still relatively unknown. One of the reasons is that there are no prospective randomized trials, particularly in children with pulmonary insufficiency after repair of tetralogy of Fallot. Currently at CHOP, we're in the process of submitting an ART-23 together with several of your institutions, Emory as well as Cincinnati and Washington, D.C., looking at teenagers and adolescents and randomizing those patients to follow up with 1 year and a half just with observational data versus randomizing to either a surgical pulmonary valve replacement versus a percutaneous pulmonary valve replacement. If you look at pulmonary valve repair, it may be a viable strategy, but really we don't know a lot about the long-term results. There's not a lot of information published, and all the choices of pulmonary valves are going to have limited durability. It seems that with percutaneous pulmonary valves, patients are going to be coming sooner to implantation, but considerations really need to include the durability of the percutaneous valves and, like I said earlier, the need for repeat interventions in these patients. I can tell you after taking out several Melody valves for infectious reasons, I can imagine that we're going to be doing a lot of surgery taking out pulmonary valves, percutaneous pulmonary valves, once we have layering of several of these and residual pulmonary stenosis as a result. Percutaneous valves are going to be approved for the native RV outflow tract. They're certainly not going to be approved as widely as I think we originally thought, mainly because many of these TETs are coming back with the transannular patch and an RV outflow tract that's 4 to 5 centimeters in size. They are not candidates for either one of these percutaneous valves. So the size of the RVOT is going to limit these, and then obviously patients who continue to have significantly, hemodynamically significant lesions such as pulmonary artery stenosis that is not amenable to stenting, and ventricular septal defects, for example, are going to be patients who we still see coming to surgery.
Stephanie, thanks. That was really a nice review. I'm sure people